can give me a little overview of kidney function.
Yeah.
Filtration. What are the kidneys responsible for?
Red blood cell
Production of red blood cells.
synthesis of vitamin D to
Elimination.
active form.
So any ideas of what can happen if you have any alterations with anything going on with your kidneys? Any ideas of what signs and symptoms you're gonna have?
Pain, kidney stones. Yeah. Pain, kidney stones. Pain in your back.
Well, that can come kind of later with other issues,
Oh.
but decreased urinary output.
Oh.
You want to get in the mind frame of what's going on with the patient with any kind of alterations that of the regular functions of the kidney.
Okay.
Regulation of acid-base balance. If you have any kind of alterations, you know you're going to have electrolytes that are abnormal. Regulation of red blood cell production. If you have decreased RBCs, what's that doing to the kidneys? Decreased red blood cell production.
Kidneys are shutting down.
Well, not probably just right from the start, but if you have decreased RBCs, you know you're going to have decreased perfusion going on to the kidneys. So therefore, that's causing the kidneys not to operate normally, right? Just the basic anatomy of the kidneys, you know the left side is slightly higher and longer and narrower than the right side. Kidneys normally shouldn't be palpated. The urine just flow from the kidneys to the bladder, and then you know it comes down out through the urethra. So if you have any malfunction that goes on along any area of this kidney, this is probably where you're going to have signs related to those kind of conditions where you have alterations in those areas. The internal structure of the kidney, you have the nephrons, and you know probably 75% of your nephrons are lost before you start having any kind of signs and symptoms of decreased kidney function. Those are the powerhouse, the working of the kidney, going through the nephrons and doing the cleansing before it starts to come out and be eliminated. Whenever you're assessing your patient with any kind of issues with excretion, you want to make sure you assess their pain level. That'll kind of give you an idea of what's going on with the patient, where they're having a pain, if it's plain pain or bladder pain. Like I said, it kind of gives you an indication of what's going on. Fever, chills, dysuria, if they're having any problems urinating, if they're burning or having pain on urination, blood in the urine, if they're getting up at night. Sometimes with men, what could be a reason getting up at night? Enlarged prostate. Okay, anuria, that's just no urine at all. So what could you think of that would possibly cause you to have no urine at all? Blockage. So these are things when you're developing a history, you want to do a thorough assessment, and then you can kind of start getting an idea of what's probably going on with the patient and develop the treatment interventions that you want to do for them. You want to monitor, I know, because you know decrease, I know it's going to represent a decrease in kidney function. And any weight gain or weight loss that could be due to dietary changes or maybe due to the kidney malfunction, that whatever they're taking in is not maintaining their nutritional value because they're having the decreased kidney perfusion, and whatever they're eating, their body is probably not absorbing it. Okay, risk factors for developing kidney failure could be advanced age, because you know with age, You're gonna always have decreased kidney function. You're gonna have a loss of nephrons as you age. Immobilization. Immobilization is gonna have effects on everything that goes on with your body. Everything is decreased whenever you're immobile. Diabetes can affect the nerve cells of the kidney, the flow of perfusion to the kidneys, and hypertension is always going to cause decreased perfusion to the kidneys because of the high flow of the blood content that's increasing the blood levels that's causing the hypertension. As I told you, the kidneys aren't usually palpable, the right kidney especially. And you want to percuss for anything after the patient has voided, because if they have urinary distension, you don't want to be pressing on a full bladder. And sometimes with patients after they void it, you want to assess them after they void it. They have something called a bladder scan sometimes with patients that may have urinary retention. And after they void it, you can assess their bladder to see if they have any stasis of urine and not completely emptying their bladder.
Ms. James, the hypertension causes decreased perfusion?
The hypertension over time is going to decrease perfusion to the kidneys. And hypertension is one of the leading causes that patients will end up with kidney failure. Diagnostic assessments that go along with finding out what's going on with the patient that's probably having problems with excretion, urinalysis and urine culture. Color, what would you expect the color of the urine to be? Normal color of the urine or normal?
Oh,
Normal color of the urine.
yellow clear.
So if you're having problems with excretion, you're going to be looking for what kind of changes of concentration.
It's gonna be darker.
Dark urine, and if they have blood in the urine, you're looking for hematuria. So color and consistency is very important. pH of the urine could be more acidic with UTIs and cystitis. The urine-specific gravity and osmolarity. Those are all signs that they're having any kind of decrease in function. The specific gravity and osmolality would be increased. You want to assess for protein in the urine because that could be a sign of breakdown of muscles, glucose, ketones. Ketones is for pregnant women is an indicator that she's probably going into eclampsia. So that's why getting lab values is always important, and usually with pregnant women they're going to be getting this every time they go to their doctor's visit. Your serum lab values like your BUN and creatinine, you want to assess those because BUN and creatinine are usually elevated with any kind of kidney failure. And like we said, electrolyte imbalances, hyperkalemia, low sodium. Low sodium is sometimes an indicator of early renal failure. But as renal failure progresses, the sodium levels will become higher. And CBC, that's all part of the red blood cells with decreased perfusion. You want to do the PTT, and albumin, that's another indicator of kidney failure. Increase in albumin gives a sign of the stages of kidney failure that a patient is reaching. And along with the GFR rate, it gives an indicator of when they should start dialysis. The higher the albumin and lower the GFR gives them the stage of renal failure that patient has gotten toward, and so it kind of gives them an indicator of when they should start preparing them for dialysis if they're getting there. Or it can give them an indicator of starting some preventive measures to prevent that patient from going into further renal failure. And the imaging scans are just all of those, the KUBs, ultrasounds, would just give a basic overview of like looking at the kidneys, ureters, the bladder, and seeing where may have been finding where any obstructions are.
I have a
quick question about the sodium. You said the low sodium is indication that the kidney is failing, and the more it fails, the higher the sodium level goes up?
Sometimes if a patient is in renal failure, if the sodium, in the beginning, the sodium is gonna be low.
Okay.
Yeah, so that's an indication of the early stages of renal failure, but as it progresses, the sodium level will start being higher.
Okay.
Okay, and this just, the basic nursing care of a patient undergoing the, diagnostic testing for any kind of renal failure, because when patients are getting into renal failure, and possibly get to the idea that they probably have to end up getting dialysis of some sort, you want to assess the psychosocial effects that it probably have on a patient, any lifestyle changes that it's having, going over their fluid intake. Sometimes dehydration is a leading cause that they're ending up in renal failure, or possibly kidney stones. Checking their hygiene, you want to educate them on that, because you know with women, as far as hygiene, improper hygiene can lead to a lot of issues with UTIs. The presence of the pain or discomfort will give an indicator of possibly what's going on with them, and assessing them for any allergies, and that's going to kind of let you know what medications to order, or if possibly they're on something that's causing them issues with their kidneys. Patient teaching, describing to the patient what kind of test and what the test is for, and giving it in a language that the patient will understand, because you know most people probably have a 5th to 6th grade reading level, so you want to educate them on a level where they can understand, and that's what it comes with using appropriate terminology. Encourage fluid intake unless it's contraindicated. You know, with patients CHF, you probably can't encourage them to increase their fluids, but you can educate them on what proper fluid intake they can have to keep them from going in congestive heart failure, and also keep the kidneys flushing. And instructing on methods to reduce discomfort, such as the 6 valves or relaxation techniques, and sometimes they have medications that can numb the pain if they're having any kind of burning during urination. Assess their voiding and instruct the patient on proper voiding. As far as nurses go, nurses sometimes are the highest patients with renal dysfunction and why is that? Yeah, you're probably working long shifts, and you're going all day not using the bathroom, so proper thing to do is to try to void at least every 2 to 4 hours, whether you have to or not. And that's a thing that you can educate patients on as well. And also increasing your fluid to make sure that you're stimulated to go and flush your kidneys. And you want to provide the privacy and respect to the patient whenever you're going over this with them. Okay, adult urinary dysfunctions. You want the nursing management for urinary incontinence, because people with urinary incontinence tend to limit their daily activities or may not even want to leave home. Teaching them how to use pads and go to the bathroom frequently to change that so to avoid the odor. You can educate them on things like that. As far as the urinary retention, discuss with them the causes of the urinary retention, and it's good to find out what is the reason for the retention. Some people who are in a hospital may have Foley catheters, so you know you're monitoring the addional of the catheter, the consistency and color of the urine, and catheter in the hospital. What's the #1 risk with catheters? Catheter-associated UTIs. That's the #1 reason. It increases hospital stays, increases cost. So a patient that has a catheter, usually after 48 hours, you want to reassess. Sometimes bring to the attention to the doctor that they've had this catheter longer than needed. If the patient's able to get up, you want to go ahead and get that catheter out of them because you're actually opening the window, the entry of infection to that patient.
48 hours.
Usually after 48 hours, you want to try to start removing the catheter, especially after a patient's had surgery.
Real quick, what is, can you clarify more on bladder retraining? Like, is that after you've taken the catheter out?
Yeah. Bladder retraining is going to be the like
Like when you
Kegel
get 'em up.
exercises,
Okay.
Kegel exercises to strengthen the bladder. And you want to tell them how to limit their fluid so it doesn't increase the pressure and cause incontinence. And the voiding every 2 hours to gain their bladder control.
And that's the Kegel is just like squeezing in.
And that also helps avoid urinary leakage.
And so you would want them on a strict schedule, like every 2 hours, trying to get up.
Yeah,
and
when
down.
you're doing a bladder training. And like we just discussed, with the Foley catheter, you got these increased risks, UTIs, urethritis, cystitis, urethritis, and pyelonephritis. You know, the pyelonephritis is after that infection has migrated up further and causing more issues with the patient with their symptoms. The cystitis is inflammation of the urinary bladder, and as we said, that's catheter-associated UTIs increase the risk of that. But for women, what are some of the reasons women end up with cystitis?
Wiping the wrong way.
Wiping the wrong way. Yeah, sex. So what you want to teach them with sex for prevention? Avoiding after sexual intercourse. And also with sex, what else can be a thing that causes women to get UTIs?
Ooh, okay, you go right on ahead. Haley. Pass me those. Give me the ones you cut too.
And actually, that's
Give me everything.
increase for men. You know, if you have
You
men
can give me them, I'll
who
cut 'em.
have a lot of anal sex and
Grab those.
men on men sex, she's right.
No, you can't stretch.
But that's not where I was going with it. But look, that's a question on the patient's history to ask the patient their sexual preferences and what do they do sexually, and that'll give you an indicator what's going on there. Because you probably have a patient that
too much
keep
for
coming in with recurring infections, and that could be a reason why.
Getting it on.
A lot of obese women have an issue, like really, really obese women have an issue because they can't wipe good.
But other reasons for women, because this don't usually affect, women, why are we more prone to get UTIs?
They're so warm.
Okay, so with that being said, another issue that can cause women to have an increase.
Because ours is on the
Always get
inside.
uncomfortable. You know what I'm saying? Like the uncomfortable subject.
But once you get in this field of doing this, it's going to be nothing to you.
Oh,
You
no.
go up in there and pop it out like a run. It's nothing.
Well, Melissa was just talking about that.
But
Not
with
for
sexual
nothing.
intercourse for women, use of spermicides, jellies, and things like that, that increase cystitis in women, and shower gels. We kind of got a little bit off track.
Got her mind off track.
But a number one bacteria that is in the anal area that increases the risk of UTI.
E. coli.
E. coli. So see, she's right, y'all. Y'all gotta know this stuff. So it's important to ask people again about their sexual practices.
Just clean it out good before you do that, I guess.
You want to ask if they have any kind of pre-existing conditions like diabetes. A lot of people with diabetes have a high risk of yeast infections. So they'll have a high chance of UTIs associated with that. Any kind of anatomic or functional abnormalities of the urinary tract increases their risk. And pregnant women.
Bless you.
Also obstruction or chronic kidney disease and people who are immunosuppressed, HIV patients, or even people with lupus and things like that, they have a high risk of this.
Diet affected, like you guys, like for someone, they drink and stuff.
Well, yeah, if they have a high concentrated content and they're not flushing, drinking clear liquids and high sugary and carbonated beverages, caffeine, that can increase your risk. So whenever you probably end up with an issue like this, you want to limit that because that can aggravate your bladder.
So if a woman goes too long without treating a yeast infection, it can become a UTI.
Yeast infections and
And chlamydia,
all be
too.
interrelated.
Yep.
Yeah, untreated.
Cranberry juice
infection
can
becomes
help with the
chlamydia.
acidity of the bladder, but it's not a proven juice that really helps with UTI. But they say that cranberry juice can decrease the acidity of the bladder. But mostly the cranberry juice, you're drinking it and you're pretty much just flushing your bladder out anyway, just like with drinking water.
Did they say to eat yogurt?
Yogurt's yeast infection. Yeah.
I thought it was like for UTI.
Yeah, well, if you're decreasing yeast infections, you're decreasing your chance of UTI. Put it on. But you want to teach preventive measures.
Buttermilk.
For women, you want to long hot baths. Increases the chances of UTIs. Avoidance of using the soaps, the jellies and stuff like that, and increasing her pill fluid intake. As we said, the sexual intercourse and wiping from front to back. You want to teach proper hygiene to avoid issues with UTI. You want to, when I was saying this can further develop, this UTIs, if left untreated, can turn into urosepsis where it ends up in the bloodstream. And that's why this can become very serious because this relates to 30% of mortality rates with people that go undiagnosed and untreated.
What did you say can lead to?
Urosepsis, infection in the blood.
So the most common one is the C one.
Cystitis, and it's probably more common in women, but as it progresses, it'll travel up into the other systems and cause infection in those areas. Urethritis is mostly going to be associated with sexually transmitted infections with males because
They got dirty.
Now we got one.
yeah, so that's an increased risk to the males that women don't get. Well, we get it, but we don't have that increase like this.
Oh, nasty.
And with the pyelonephritis, you want to manage sufficient perfusion to the kidneys. You want to maintain a mean arterial pressure greater than 65 with any of these. I wanted to just break it down for y'all. Like the cystitis starts off in the bladder, and urethritis travels up through the urethra. And the pyelonephritis is going on further up into the kidneys. So if they having pyelonephritis and it's in the kidney area, where you're going to be expecting them to have pain? Plain pain. Okay. Okay, the lower urinary tract infections, we kind of talked about this too. We said the organism most responsible for UTI is
E. coli.
E. coli and also Pseudomonas and Enterococcus organisms. The most common route of infection for UTI, what's the most common? How's it getting in?
Through the
By the
ureter.
Wait, what?
through the urethra.
That's what I
Okay.
said.
That's what I said.
Anything
I did.
with the urethra,
not what I
that's
said.
the port
This is
a
of
vagina.
entry for these infections. Okay.
Sorry.
Okay, we talked about in women, we're high resistance because we have the short urethra and a higher chance of moving bacteria into the urethral tract. Sexual intercourse, we all jumped ahead. Sexual intercourse forces the bacteria up the urethra. And bacteria may enter the bladder from the blood, from a distant site of infection. Because also if they have high incidence of staph can enter and be that portal of infection. And UTI is the most common bacterial infection seen in patients over 65. Okay, it's associated with decreased bladder tone. You're going to see patients with urinary retention have a higher risk of developing UTIs, neurogenic bladder, and as we said, BPH in men, because you have the enlarged prostate that's squeezing against the bladder wall. So men have urinary stasis, and urinary stasis is accumulating bacteria because you just got urine sitting in the bladder area. Clinical signs and symptoms that may be present. What we talked about, the back pain, blood in the urine, dysuria, cloudy urine, and urine that's been sitting a while, that's cloudy, full of bacteria, what you expect of it.
It's gonna stink.
Foul odor. Have y'all ever been across that on any of your clinicals? You can smell it a mile away. Sometimes if they just even had a little incontinence in their underwear, you can smell it. Some gerontologic considerations is the most common symptom for UTI and fatigue. And UTIs with elderly people may not present as urinary tract symptoms. You may have confusion noted, and you're going to see people that's they're real having an increased chance of falls. Okay, some nursing interventions for the urinary tract, relieving pain, therapy, sometimes 6 baths, proper hygiene, we talked about that, increasing the fluid intake, changing their voiding habits, and assessing for whatever complications they may have that you want to try to help them modify.
So would antibiotics be part of those?
Antibiotics, the doctor's going to prescribe that, and you want to teach them the proper way to take the antibiotics, and that they have to finish the antibiotics. Avoidance of things like that's going to make the urine acidic, like orange juice with vitamin C and stuff like that. Yeah. Yeah, well, anytime you take an antibiotic for women, we have a higher chance of developing the yeast infection. So with that being said, you can tell people that take eating yogurt along with it, or maybe the doctor might give them antifungal to go along to take probably a couple of days that she's about to be finished with taking the antibiotics. And you want to tell them to limit things that may cause spasms to the bladder, like the caffeine, coffee and stuff like that. Some medications like the antihistamines can increase spasms in the bladder, so you want to talk to them about stuff like that. And sometimes doctor may prescribe them medications that limit the spasms. A shower rather than being in the bath, wiping front to back, increasing their fluid intake to flush the bacteria, avoiding urinary irritants, like we said, the coffee and the citrus, and frequent voiding. Recognize complications such as renal failure, sepsis, and strictures, any kind of blockages. And like we said, avoid indwelling catheters too long over time. That's a source of infection. And they said remove it at the earliest opportunity. And in the hospital, we actually have people that come around, court measures. They're like their police in the hospital that they're checking patients' charts periodically. And it's important that we know when we started the catheter, because they come along and they're constantly reviewing these charts to see how long some of these patients have had these catheters. And if it's been brought to the doctor's attention that the catheter should be removed, or what are the risks to this patient that they still have a catheter. You know, if it's a patient that's bedridden, you know, they're gonna always keep a catheter. But people who just probably had like a hip surgery or knee surgery, you want that removed within 48 hours, or whatever surgery they probably had. And usually women, after having a baby, if they had to get a catheter, like for a C-section, they usually take that out right after C-section. Use strict aseptic techniques to maintain cleanliness and avoid infections. Whenever the need for a catheter comes along, you want to use the smallest catheter possible. And also you want to perform daily perinatal care on these patients when they have catheters. And pretty much, and we talked about retraining the bladder. People with lower UTIs, even if they're on antibiotics, you want to tell them to constantly increase their fluid intake. You want them at 3 to 4 liters a day to try to push out the bacteria. And also, if they have, well, we'll talk about that later, but constant measuring their INO and assessing their temperature, because if the temperature is constantly spiking, it's showing you that the infection isn't going away. So whatever treatment is happening is not being effective. And administer the antipyretics and antibiotics as prescribed, and teach the patient, like we said, about finishing the antibiotic completely. Some renal disorders that can develop with any kind of renal failure or any kind of alterations in your excretion. Could be the urolithiasis, nephrolithiasis, glomerular disease, chronic kidney disease, and acute renal failure. Like I said, with acute renal failure, in the beginning you're going to see decreased sodium, but as renal failure progresses, sodium levels will go up. Part of the reason for a lot of issues would be the urinary tract stones and kidney stones, and depending on where the stone is, you'll kind of assess that based on the patient's symptoms. Some stones can be small, and some can get as large as an orange. I'll tell you a story.
Oh no, mine was big, but it wasn't like an orange, that's for sure.
Do you know what kind it was?
No, if all I know is that it couldn't come out on its own. So, because it was too big and they couldn't do the laser and all that, so.
So what kind of treatment did they do?
Well, they had to do surgery to remove it.
Okay.
And I think it was like a size 9, so it was pretty big.
Okay, so what kind of pain did you have, and you know how long you had it?
The pain usually happened when it was traveling, when the stone's moving, they say.
Mhm.
But it was, I could go from sitting here talking to bent over crying. It was just, it was incredible
Do
pain.
you know where the stone was?
What
Because
type?
depending on where the stone
Yeah.
is,
Mine was stuck in my ureter, or, yeah. It was stuck there, it wouldn't, because it was too big to go through.
Do you know
Okay.
what type it was?
I should have asked all that, it was years ago.
Yeah, they usually test them after you had stones to determine, because
Where it
all of
came
that's
from.
going to tell you what diet
Yeah.
changes you may need to make and everything.
It's the only one I've ever had, but,
Knock on wood.
thank God.
Yeah. Okay. Stones can form from calcium oxalate, phosphatase, and increased uric acid. And like I said, they vary in the amount and size. You wanna know the etiology behind it, what's causing it, a deficiency in substances or whatever. Dehydration is one of the leading causes of development of stones. And sometimes if you just increase that patient's hydration, they can flush a stone. And if they continue that therapy, they probably will never develop a stone again. Immobility can be a risk for developing stones and increased calcium in the blood and the urine. Other factors for stone formation can be infection, the urinary status of the patient, and anything that delays renal drainage, and or anything that's increasing calcium production.
So if you're on a calcium supplement, would you want to watch for that? Or does it not work like that?
If you're on a calcium supplement, it's pretty much okay unless you have some issue that you're not getting the calcium out of your system. If you're having increased kidney function, your kidney function's okay, calcium supplements aren't going to affect you. But if you're having too much calcium that your body can't metabolize it, you put yourself at increased risk. But it's all kind of the potential of the person, because everybody doesn't have that potential to develop stones. And your kidneys probably can't perfuse enough to get whatever accumulation of calcium you have out. So it just all kind of depends on the person. And this just giving an overview that I just talked about for some of the risk factors that can cause a patient to develop stones. Men have an increased incidence of stones, and these stones called true bites is more common in men. But this is the difference of how the stones can accumulate. You can have some stones that are just as small as a grain of salt, so they're easy to pass. But they can accumulate and get as big as an orange, like I said, and sometimes they're going to have to go up in there and break them up. But if the patient gets to where they can't pass them, it's always going to end up being surgery. And they'll usually send patients home with a strainer or something to catch the stones, and that they want you to catch it so they can assess it and see what the content of the stone is.
And they also put like a catheter, like Magadget up in there. Yeah, that thing.
Yeah, they'll do that sometimes to keep the urethra open to help it easily pass, or put it further up into the ureters. And these are just the different types of stones. You got the struvite, the calcium oxalate, and ammonia, cystine, and silica. And all these stones develop based on what you have in your diet or what you have the potential of accumulating. And like I said, women have a higher tendency for the struvites. Recurrence of stones are increased if you have a family history, and or if you had a stone by the age of 25 years of age, you kind of more than likely probably have more stones occur. The cystine stones have a high urine acidity, and those are the uric acid stones, and that's probably with patients with gout. They have a high tendency to accumulate uric acid. So you want to teach them to increase their fluid, because patients with gout have a high tendency to develop stones, and you also want to talk to them about their diet, because they already have gout, so you want to tell them how to limit any uric acid in their diet that can inflare their gout or cause them to develop stones. And with stone formation, if you have a blockage and you imagine that this stone is causing friction in the ureters, what would you expect the urine to look like?
It's gonna be.
Yeah, you may have blood in the urine, dark, rusty colored urine. And you want to, main issue with stones, you want to try to promote comfort, pain management, and increase the fluids, because you're trying to get that stone moving. And these are some symptoms that go along with having a stone. You're gonna have people with severe pain, and that's called renal colic. And a lot of it is a sudden onset. You'll probably notice a patient that's all of a sudden complaining of pain, nausea, vomiting, diaphoresis, and that can kind of give you an indicator to look for a stone, especially if they're having flank pain. Flank pain is stone in the kidney or upper ureter, and it can extend to the abdomen or the scrotum, or the vulva. And if you have patients that's having pain that's increasing in those areas, that's usually meaning that stone is migrating into the ureters. Pain is more intense if the stone is moving and or the ureter is obstructed. And like I said, you're going to notice nausea, vomiting, diaphoresis, and sudden onset. If they have urinary tract obstruction, and what's going to give you an indicator that they have some obstruction?
I'm not gonna hear.
No urine formation, so that's an emergency situation, and you probably have to go ahead and get lithotripsy to get that broken up. A urinalysis is always going to be done. They're going to get a pH level, a urine pH, to determine the type of stone.
And that's just calcium? Is that just calcium?
Is this just calcium? No, these are different views of stones, but this is just a view that's telling you what a patient goes through. With the slide before, kind of shows you the different ones. Yeah, those are like the calcium. You see how the little the one at top is the calcium oxalates. And like I said, this all going to develop based on what you have in your diet or whatever you have a tendency that you're not excreting out through your urine. Okay. And this is more on urinary kidney stones. You got 75% of all stones are calcium based. So that's why you want to get the content of the stone. If you have a patient with that tendency, what you're going to tell them? With their calcium intake.
What if a patient gets a calcium stone that don't drink or eat calcium at all?
It could be a breakdown of their bones, dystrophy. You're going to find the underlying cause of what's causing them to have that breakdown in calcium in their body. Because a breakdown of their bone can cause
Like the generation in their bones is what you're saying?
any kind of osteodystrophy of the bones can lead to that. And like we said, oliguria and inuria is you want to observe them for any urinary obstruction. You want to get a history of their diet, their fluid intake, any family history, supplemental vitamin intake, like she said, or if they have any kind of mineral intake. A chemical analysis is usually always done when a patient has stones. And the most common issue for stone formation is the dehydration, like I said. Most stones contain calcium, and that's with excessive amounts because calcium is absorbed from the intestinal tract. So you want to teach the patients that about if they're having any kind of increased supplements, that's what's causing the increase. 15% of stones are struvite stones, and like I said, women have a higher potential for that. And 8% is the uric acid, and uric acid is mostly with people who have gout. You have two processes that stones form: the supersaturation in the urine, and supersaturation is you have a supersaturation of whatever in your system that's causing that stone to develop, or formation of nidus, and that's deposit of crystals that can be the point of infection. Any kind of stone obstruction can threaten the GFR and kidney perfusion. And if you having stones that stay in there for a long time, just like you have patients with BPH and stasis of urine, and the urine is backing up, stone formations will do the same things where they have that hydroureter, the expansion of the ureters, so that urine flow may be decreased. So that's why you want to push their fluid so they can have a strong flow to get that stone out. And symptoms of the stones is going to be the decreased flow in urine, distension of the patient. Signs of infection is going to be the fever, chills, frequency, urgency, and urosepsis. Like I said, that can be life-threatening. That increases like the chance of mortality by 30%. So we'll go ahead and break. I'm gonna let Marcy come in and see what Miss Weary. Let me get her because she wanted to come in and talk to y'all a little bit before we broke. So y'all can kind of get through it, right?
Haley, you gave me you passed me everything?
Yep, this is all I got for her.
Okay.
With pain, for the pain and increasing the fluid intake, you can pass a stone that's 0.5 to 1 centimeters. KUB? Kidneys, ureters, bladder.
It's an X-ray.
That's where they can go in and they can view the kidneys and the ureters, and if there's a stone, they can see where it is. Sometimes they may have to go in and put in stents, and if a patient have stents, they're gonna constantly have hematuria until the stone is passed. And also they can use catheters at times to help pass the stone. And like I told you, they're going to use things to catch these stones so they can see what type of stone it is. And the objective is to eradicate the stone and control infection and prevent any destruction to the nephrons. Nursing interventions is pain relief, like with opioids or NSAIDs, hot baths or moist heat to the flank areas, high amounts of PO fluids around the clock. And if the patient isn't able to take it in orally, you can give it to them IV to try to get the increase of fluid in the body. Ambulation helps move the stones, so you want to encourage them to get up and ambulate. And you want to go over their nutritional therapy of what's causing the stone. With oscillate stones, you want to tell them to avoid things like spinach, strawberries, rhubarb, and chocolate. And cystine stones is they're gonna be on a low protein diet. With uric stones, like I talked about with patients with gout, they're also on low purine diets. And you want to tell them avoid like the organ meats and the shellfish, especially like shrimp. Sometimes if they have an intake of foods like that, they'll probably have an exacerbation right away. And medications like allopurinol that patients usually take for gout can help with the uric acid stones. And these is just a diagram of some of the strains they use to catch the urine in the third picture. And everything else is just measurements of the urinary output and trying to see if they catch the stone, because if you have a catheter and you get the stone through the catheter, you still want to pour it through that strainer and get the stone so they can evaluate the stone. When they go home, they need to continue increasing their fluids, and sometimes they'll be sitting home with the strainer to catch the stone, and they're educated on how to use it every time they void. Drug therapy is initiated to what's causing the stone, and like I said, the high calcium intake in the urine. They can have some thiazide diuretics like HCTZ can help flush that out, and decrease the calcium loads in the urine. allopurinol for the high oxalate stones. And like I said, tell them to avoid the spinach. And decrease cysteine with medications like captopril, the ACE inhibitors. Those can help decrease cysteine stone formation. With struvite stones, you want to limit high phosphatase like organ meats and dairy products. And the uric acid, you want to decrease the intake of the purine sources like we talked about with the organ meats, fish and poultry, and even sardines.
So with the, you said to avoid spinach with which one?
With the
Oxalate.
yeah, the oxalate stuff.
And is that just spinach or does that include like
No,
kale? and-
anything with the high purines and proteins up in it.
Okay.
Okay. Glomerular disease, glomerular disease is the inflammation of the glomerular capillaries, and it can be acute or chronic. Glomerular is associated with hypertension or progressive kidney damage. Like I said earlier, diabetes can cause kidney damage, and it'll result from anemia, from decreased production of erythropoietin. Decreased RBCs can lead to the kidney failure. Chronic glomerulonephritis is usually developed after decades of infection, hypertension, or any kind of inflammation or perfusion to the kidneys. It's also known as chronic nephrotic syndrome, and it can occur after post-infections like strep, impetigo or viral infections, even patients who've had flu. So that's sometimes a good question to ask the patient if they had any kind of recent infections. We need to know that they have glomerulonephritis. Causes of the repeated episodes of our acute glomerulonephritis. Chronic can develop after they keep having the episodes of the acute. They're going to have symptoms of hematuria and anemia, ongoing hypertension, and oliguria. That's going to be decreased urine production, and malaise and weakness due to decreased production of the RBCs. Elevated BUN and creatinine results from that, and you want to treat the edema and hypertension with fluid restrictions. Maintain a low sodium diet. Sometimes loop diuretics can help, and the ACE inhibitors or calcium channel blockers. This can occur when a group of disease